Welcome, everybody, to Health AI Hub. Today, we are welcoming back a team from the Light Collective to Health AI Hub to talk about their recent research report called Tangled in the Web, Patient Safety and Privacy Concerns when Seeking Knowledge, Community, and Support Online. Light Collective is an organization dedicated to amplifying the collective voices of patient communities regarding the use of health technology. They recently drafted this report based on community-led surveys that sheds light on complex relationship between patients, patient advocates, caregivers, the digital world they navigate, and they seek to understand and manage their health condition or of those whom they care for or advocate for. Please welcome Christine von Rasfel. Christine is patient advocate and ally in rare and chronic disease community, working as board member of the Light Collective and also with Research to the People. Please welcome Valencia Robinson. She's Director of Community Outreach for the Light Collective. Valencia is nationally recognized advocate and founding member of the Light Collective. She serves on the board of the National Breast Cancer Coalition and Florida Breast Cancer Foundation. Valencia has also founded the Women of Color Wellness Alliance in 2022. And please welcome Andrea Downing, co-founder and board president, Light Collective. Andrea is the co-founder and board president. She has been a prominent figure in health privacy research, focusing on implications of technology and social media on patient data privacy. So welcome, team. Thank you for your time today, and I'll give you the floor.
All right. Thank you very much. Andrea, you're ready with the slides?
Yep, let me go ahead and share. Give me 1 second here.
Okay. Okay. All right, I'm Valencia Robinson, an 18-year survivor of triple-negative breast cancer and a founding member of the Light Collective. And we thank you all for joining us today for this conversation. And as patient advocates, our mission is to advance the collective rights, interests, and voices of patients in health technology. And we work with these patient-led grassroots organizations to educate patients and their families on all aspects of digital rights, patient privacy, and now artificial intelligence in healthcare. So this shows you all of the patient-led organizations that we've worked with. And this slide here gives you all of the events and all of the conferences and all of the places where we share publicly, nationally, and it has really been great work. So now I'll turn it over to Andrea Downing to review the findings of our latest research.
Thank you, Valencia. So as mentioned, today's topic is focused on a new community-based study that the Light Collective did called Tangled in the Web, Patient Safety and Privacy Concerns when Seeking Knowledge, Community, and Support Online. The lead authors of this included Dr. Maya Rockymore Cummings, who could not be here today, unfortunately, but we were so honored and proud to work with her and Johns Hopkins University on this IRB approved study. Also with us is Jill Holdren, one of the leads on the analysis within this study. Jill is going to be listening in. She is going through cancer treatment, and I hope I make her proud by presenting what she would normally present, and really just I'm going to dedicate this to one person, but I also, Jill, want to dedicate this to you. And finally, Valencia is also a lead author. What we'll cover today is the methodology, some of the study highlights, a deeper dive into our findings, study limitations, Q&A. And I want to begin with why we did the research the way that we have. Let's start with the fact that our constituency within the Light Collective is member-led organizations who are serving patient communities. And when we think about the approach to this study, these were the community partners who helped us co-design and create not only the survey questions, but work through all the way through to the dissemination strategy that we took. I want to thank each and every community partner that worked with us on this research. I also want to dedicate this to one of our founding members, Marlena Murphy. Marlena was a community organizer with a wonderful research organization called Grasp Cancer. And she was part of our first cohort. Unfortunately, this year, upon completion of the Patient AI Rights Initiative, we lost Marlena to stage 4 breast cancer. And we are very grateful for the gift of our time as we carry this torch and her message on digital rights, privacy, and patient safety. So now I will get into our methodology. For those of you who may not have heard of this approach before, we took a community-based participatory approach. And that essentially means two things. When we look at community-based studies or community-based participatory research, the goal is to equitably involve community members, organizational representatives, and researchers on equal footing. And community partners are tasked with contributing to all aspects of the research and shared decision-making in the design. So when we went back to the acknowledgements that I just shared, in every step, they were co-creators of this study, from the framing of priorities of questions to what the things were that we wanted to learn about our network. I highly recommend these two citations for anybody on this call who would like to learn more about CBPR. You can also check out the resources at PCORI, the Patient-Centered Outcomes Research Institute. They have a lot of great resources there. This study was made possible by the Robert Wood Johnson Foundation. We want to thank them for their generous support through the Pioneering Ideas program. And this is the suggested citation if you would like to take any of these stats or reference this in future papers. We always encourage that. We'd love to be able to show that impact. So I'm going to very quickly start with some demographics of how we looked at our community and respondents. So as mentioned, this study looked at network affiliation. We went to our member networks and we had 377 respondents in total that were part of community networks served by advocacy organizations affiliated with the Light Collective. We tended to be on the older side with 75% responding on this question. I'm sorry, 65% of participants were over the age of 45, and our education level was 75% bachelor's degree or above. We are working within the Light Collective to bring more diversity into our responses as we do further research. And I will share more at the end about the caveats or some of the ways in which we want to make sure we communicate our study limitations. So for the Health AI partnership, there are two key statistics that I think are really rising to the top and things that we'd love to take away with this group. The first is 91% of patients and caregivers in our network wanted to be informed if AI is being used to make decisions or communicate during care. And we know that's not happening today in most places. So as AI emerges, there's this overwhelming sense that we need transparency. We need to know if this is being used, if this technology is being used at the point of care. 97% of respondents in our network are at least somewhat concerned about ways that AI can negatively impact health or care. Now, I want to take a step back and say that first, this study was not just about AI. So, we wanted to start with kind of the punchline for Health AI partnership and this community audience. But what we were really thinking about is, we exist in the context of the technologies that came before AI. So let's start with how we think about the last wave of innovation in social media. Patients go online and post on social media for knowledge, community, and support. In fact, online support groups are widely embraced within our network, 73% participating, with Facebook being the primary platform used. Other platforms like Instagram, Zoom are also used, and social media platforms play a crucial role in health information sharing, with many using Facebook or Instagram to search for health information on a regular basis, with 57% of people indicating they use these platforms at least weekly. So this is something that is a very common practice within our network. Anecdotally, we talk about this a lot, how many advocates and organizers use social media, and yet patients have safety and privacy concerns when they use the internet to search for and exchange information about health. Let's recognize anything that we post when we look at the broader context of policy, anything we post on social media, anything we search for, or anything we put into ChatGPT is not covered by HIPAA. So when we look at some of the numbers here, the vast majority, 74% of respondents, express moderate or extreme concern about personal health data being shared without consent. 53% indicated they would stop using a health website or app if their personal information were shared with advertisers. And 25% indicated they would use a site less frequently, or 8% indicated they would use it as they always have, or no change. We find this to be interesting, especially like digging into some of the further concerns. And this really gets into meeting communities where they are and understanding where the cognitive dissonance is when we have certain expectations about how knowledge is shared, especially health knowledge about us, and what our fears or concerns are framed in our own words. So in the respondents about concerns, how are using technology to manage health challenges, what rises to the top includes hackers sharing it or getting information, companies sharing my information, insurance companies learning about my health, employers learning about my health, or even friends learning about my health when they did not wish for that to happen. And then a small amount said none of the above. I think here another part of this is, regardless of what a company privacy policy may say about advertising or how data about your health are shared, we are in a place where patient consent for sharing depends on the context. Despite privacy concerns, many users don't regularly review privacy policies. In fact, the majority occasionally or rarely read these policies, and 14% never do. 29% consistently read privacy policies, but we are still in a place where we have to check the box of consent. There's no negotiation or a way for us to mark out something that we don't like, despite hopes or expectations of privacy. Another important thing is, a majority within our network do want to share data with researchers. 64% would be willing to share with researchers, and 58% with public health organizations or nonprofits for the purpose of scientific advancement around health. So I am going to move to the next thing, which is, let's go back and zoom into our views or thoughts and expectations within the network about health AI. I think, we see the hope, and we have continued hope for AI to change the game when it comes to better screening for disease, better reducing human error and bias, improving access to care, offering more personalized treatments, providing more accurate diagnosis, or predicting future health conditions. So we had, you can see the percentages on the slide. We had 254 respondents on this question. But then there's also the question of the negative impacts. There are concerns or potential risks where a vast majority responded that they are concerned about negative impacts to their own healthcare, using health information without consent, false information or misinformation, lack of transparency on how AI makes decisions, increased security risks, incorrect diagnosis. And interestingly, and I think this kind of goes back to the need for more diversity in our network. We have a lower concern around discrimination or bias, and yet we do talk a lot about discrimination and bias as a big risk or concern in these early days of health AI. Patients do want more rights and protection within our network when it comes to how technologies are deployed and how health data are used. 91%, as we went back to that punchline at the top, 91% of us want to be informed if AI is making decisions about our healthcare or if it's being deployed to communicate with us in a care setting. And a strong majority, 76%, believe that AI needs to be regulated by the government. Patients emphasized in our network the necessity of having control over personal data usage. 86% want to have control over their personal data and how it's used, and avoiding personalized health-related advertisements. So this was also a really interesting question. 69% responded they don't want to get those pharma ads or advertisements that are coming to us about our health. We don't like them. Now, here, just as important as the statistics are the limitations. So as we said in the beginning, this is a community-based participatory approach, which means we are not a random sampling of the population. I think what we'll talk a little bit more about this, but we used a convenience sample that, although diverse in some ways, may not be representative of the general population. The statistical analysis used descriptive statistics throughout the report. Our data collection timeline was broken into two parts. We had one part during the fall of 2023 and a second part in 2024 where we realized that when we opened up the survey again, we added a gender question. So that's one of the things that we wanted to caveat. All of the responses, you may notice, they were optional. So not everybody answered every single question. So there's some inconsistency in response rates. We wanted to kind of weigh that with getting through and completing the survey if not everybody understood a question, etc. We talked about generalizability. We really think of this as a polling of our own network. We're going into election season, and democracy is a lot of democracy is about polls, right? So we might not speak for the entire patient population, but we want data to speak for our member network. And finally, temporal considerations. Health tech is changing rapidly. Even over the last year, we'd love the opportunity to continue this practice, even though it was our first. This was our very first time taking this community-based approach to learn about our network. So with that, I will give you, I think, the 4 key takeaways that we included in the kind of punchlines of the study. Number 1, we go online a lot to post on social media. We have, despite the expectations we have about privacy, we have safety and privacy concerns when using the internet to search for and exchange for information. Regardless of privacy policies, our consent for sharing health data depends on the context. And there was that section where we talked about AI. We believe in this life-saving potential for our communities to create better outcomes. And at the same time, we hold skepticism perhaps based on our past experiences around how health AI will be implemented. So in closing, I want to thank everybody again for those who were part of this. You can go back and check out our prior presentation that we did a few months ago with Health AI Partnership that built upon this work, where we created the Patient AI Rights Initiative, thinking about what a democratic process with communities affected, specifically patients, would look like as we build capacity with these established networks to practice data governance and be a part of the policies and guardrails when we think about health AI. I won't go into this because we have a whole other hour devoted to that. You could go back to the recording if any Mark or anybody wants to share the past recording for that. If you would like to learn more, please go to lightcollective.org. You can follow on, we don't endorse one social media platform over the other. So if you go to any platform and look through the hashtag #BeLikeLight, our goal is to shed light on issues that are most important to patients. And we're really thankful to be here today talking about this. So with that, I just wanted to start our conversation with a question. And we'll go to the audience Q&A, but one of the things we're really thinking about next is how might we co-develop quality measures and expand upon some of these patient community interests when this is the first time we've tried this. So, we come to you very humbly. Some of you guys are, longtime researchers, and we are patients learning and building our network and our practices as we go. So this idea that Health AI Partnership is a learning health network, we love that the concept of our learning health network and learning together to build a community of practice. So thank you. I will stop there, and I see we have some questions in the chat. So where would we like to go? I will yield the floor.
Hey, Andrea, I just wanted to make one comment when you talked about the consents and how they are so difficult sometimes for us to understand. And I want people in the room to realize that when we are patients and we're being asked to sign a consent, we're not in the right frame of mind, right? Usually it's a crisis situation. We're being asked to sign paperwork in order to get a treatment. And so I've said this before, and I'll say it again, that and a lot of times consent at the point of care is coercion. And so how do we prepare people for these consents before something happens and really build into that? So I'll leave it there, but just wanted to mention that as you touched on the consents.
That's a great point, Christine. And, I think when we there are places when we look at, how we use the internet and point of care, the way we think about consent today is an individual transaction where there's a lot of fine print, and we struggle through that process, and there's an asymmetry of power there, where a lot of Silicon Valley lawyers, if we're talking about an app or social media platform, might be really savvy and the waivers of rights or arbitration clauses that they need to put in consent. For us, it's yes or no. That's really the choice we have. And if we want you to take away one thing from this study, it's really that. There's this dissonance between what our expectations are versus the reality of the choices that we have or the rights that we have today. So, and we translated it into Spanish. I'm sorry, I forgot to say that, but that was a very important part. Valencia asked me to say that. And did I miss anything else, Valencia? Anything else you would like to add?
Well, there were some questions that we already had in the registration. Someone asked, when you search for something in Google, it impacts the ads you see across the internet. Is that the same as in ChatGPT? And yeah.
In ChatGPT. So that's a really interesting question. And, we're seeing this increasing trend. In fact, I want to give a shout out to Dave DeBronkart, who was part of our Patient AI Rights Initiative, and Hugo Campos, who have been writing under the hashtag Patients Use AI. And it's true. A lot of patients are starting to use AI for their health conditions. And that's great, but you have to keep in mind, we have no enforceable rights when we enter our medical records or our health data into ChatGPT. And so I want to draw a parallel here between where we are today with ChatGPT or a generative AI like that has no kind of formal rights under HIPAA versus Facebook. You know, we started the Light Collective after Cambridge Analytica happened, and after billions of dollars of revenue have been made on health advertising, while medical misinformation online has gotten worse and worse for our communities. Are we, you know, anywhere closer to getting more policies to protect us? No. Do we have a situation where, you know, a group like OpenAI can, you know, basically fire and replace their independent governance board? That actually happened in this last year, and we're asking ourselves, okay, well, if a company decides to monetize health data in certain ways, you know, what are the guardrails around that are aligned with the interests of patient communities? We've seen in the past what has happened when we have no rights. And so my answer to that question is, to my knowledge, it doesn't impact how advertising works today. But depending on the generative AI that you use, because there are many that are kind of sprouting up pertaining to health, there may be ways that down the line, in ways that you don't anticipate, the data are ingested into third parties and used without your consent, or used in ways that you do not want. Does anybody else want to, like, I don't want to be the only one talking.
Well-
and Mark, I see a question in here. Mark, you want to ask your question? Are you able to come on?
Sure.
And I thank you so much for having us. We really love Health AI Partnership, and we're glad to be back to talk about this work. What did you think?
No, I mean, I think these are such important points for folks to hear. I don't think people in the health systems hear enough from patients directly. So my question is about disclosure versus consent. I think that we hear from a lot of folks in the health systems that it would be very burdensome to consent all uses of technology or software when providing care to patients. So I think people see disclosure as less burdensome. So my question is, like, how valuable is disclosure if there's not some autonomy given to patients around how data or AI is used? Do you think it's a reasonable middle ground? Like, just want your take.
It's a hard question. And you're just going right for the zingers, Mark. And I love it. And I'm going to tie back to what Christine said. So, you know, autonomy assumes that we have a choice to do or not do something, or that we have full knowledge of what's happening around a technology or the use of our data. And I think so far what we're learning is, while within our own network, awareness of AI is increasing, patients don't really have a choice yet to say no. And let me go back to the theme of it depends on the context. So let's separate out and unpack this, because there's generative AI and there's predictive AI. When we think about generative AI, the example of disclosure might look like walking into your doctor's office and having an ambient note taker, you know, that generates the doctor's notes, disclose to you not only what the notes were, but give you choices not to use the tool, or give you choices on how the tool's data might be used downstream. We don't have any choices or autonomy around that today. Going over into the predictive AI space, we're seeing these increasing risk scores. Some, and this I think goes central to a lot of the work that Health AI Partnership is doing around quality measures and ways that we make sure that something before it gets to the point of care is clinically validated. You know, that is a hugely important step where we're just at the beginning of that process. So, you know, with predictive AI, what we as patients are, I think, are looking at the most is like, we don't know how these risk scores are being used. Yeah, it would be great as a first step to disclose this information to us. Like if I'm going into the hospital and somebody's, you know, disclosing to me that on my EMR, I have a risk score for sepsis of X and it's clinically validated, or the sources of data are there. I think whether we have that or not, the theme that Christine just said is when we're in a place of trauma, when we're going through our experience, disclosure may not matter either, but we still need and require autonomy. And so how do we do that? Is the big question. So I'm not answering your question perfectly. I'm kind of giving more questions, but now we're getting into the hard part about these problems. And, you know,
and even if a patient can't refuse, you know, a certain use of AI technology, I mean, you cannot refuse it if it's already in this diagnostic tool, right? It's already there. But let me know that it's being used, right? Let me know that my data is being collected. That way I feel respected as a patient. I feel valued, you know. And I just think that that should be the way that it's done. Patients need to be aware. There needs to be transparency.
And Valencia, I'm going to tack on to that as well. I'm a rare disease patient, and I react differently to everything that's out there. And so when we're looking at algorithms that are brought together by people that I don't know, that aren't like me, I'm worried as a patient, what is this algorithm going to do to my care? Right? If these people don't look like me, if they don't have the same reactions to these pills and to these, and this is forced into my care, what does that mean for me or other patients who are not the typical standard patient who don't fit into these guidelines? And I think those are things that we have to consider when we're looking at them.
So going back to the Q&A, Ji-Young Kim has asked two really great questions. And the first is, I'm interested to know if patient representatives have shared their perspectives on what meaningful consent process would look like. Have they shared with you the types of information they would like to receive about AI use as part of informed consent? So once again, this is really nuanced, and I want to point out a couple of things here. Just like we can't treat AI as a monolith, like, you know, not all AI is the same. There's generative, predictive, and predictive has all kinds of subsets where we're, you know, Health AI Partnership is trying to create that community of practice. One of the perceptions I think about, and when asking patient communities, like what our views are, is like, we're all going to agree. The hardest thing I had to learn in the last year with the Patient AI Rights Initiative is, if you get a bunch of patients in the room with really, really deep informed experience, are we going to agree on the same things? The answer is no. And guess who else doesn't agree? Scientists. Not all scientists agree on these things, but at least at the very least, what we hope to be able to accomplish is a forum for debate. And the common ground, to your first question, I want to point everybody to the Patient AI Rights Initiative and the varied perspectives that we had. So I think the link to the prior talk was posted, but again, go take a look at that. We interviewed each of the co-authors, and if you want to read more about that common ground, we are still working to get kind of this framework of not just thinking about consent out, but thinking about our collective rights. you know, that there's a difference. Oops, sorry. So the next thing is the question of, do you or patient representatives expect any input from clinicians enhancing patient rights? Valencia and Christine, you want to take that?
You want to go first, Valencia?
Well, we are getting input from clinicians. Without going too deep into this, we are working with some organizations, and as patients, we're looking at the AI tool and we're giving our viewpoints, right? So the clinicians have already done their given their feedback. Now, as patients, we're working together to give feedback on the same tool that the clinicians have given their feedback. So we are working together with these AI companies and clinicians to come up with a better way, right? So we're just continuing to do the work in hopes of finding some common ground so that patients can understand the way in which AI is being used every day in their healthcare.
And I'll add to that and just say, for me, I tell everybody AI is just a tool, right? It's not an end all be all. It's not going to solve all the problems. I need my physicians in there. And even me personally, I'm working with my own physician on my own diagnostic odyssey to figure this out. And we are looking at AI, but I would never, you know, do anything with this without my own doctor's consent. And so we're working as a team to try to solve this and figure it out. But there are concerns there as well with AI for the physicians. So I think it's something that we're all getting to at some point, but it's a combined effort.
And it's good that we are being included in these conversations. We all, the three of us and more of our board members and the patient organizations, the slide that Andrea showed, we are all in the rooms with the talks, with the researchers, with the clinicians, with the developers. So we are being included, and we just hope that they're listening to us and valuing our input.
And I know we have a couple more questions in there. And I know that
Christine, you want to go to the next question?
Sure. Well,
and take it.
Yeah. So it's Mike is asking a question. Mike is one of our board members as well. And I don't know if Mike is available to come up and ask, but I think he might be working. But he says, what do you think is the responsibility of the institution, hospital or not, to disclose that a solution, perhaps a radiology exam, is going to use AI?
They have a responsibility to tell us.
Well, yeah, I think when we come to a group like Health AI Partnership, this is why we're here, because we understand within Duke and DHI and all the work, Mark, that you are doing with this network is working to define what the responsibilities are. Our goal is, how do we partner on equal footing? Going back to my question at the end of the presentation, how do we start to create quality measures that are grounded in the science of engagement? I think one of the things we've started to uncover in our conversations is that there's this whole science of patient engagement. And I pointed to Patient-Centered Outcomes Research Institute, and otherwise known as PCORI, and their foundational expectations for partnership. If Christine or Valencia, you could put that in there. I think that's a really great place to start when it comes to responsibility of institutions, to do the basic things to build trusted relationships and partnerships, not tokenize communities or build AI about us without us. And so I think that we're just in the beginning stages of moving from knowing how science of engagement worked in a clinical setting for things like, improving diversity in clinical trials for the breast cancer community or for the rare disease community, figuring out community-led quality measures and outcomes. You know, these advocates and networks are out there, they exist, and they have done the work. In fact, Mike, I love your question because you were just at the PCORI Summit and you know so much about this practice. We have a opportunity as we're shaping the future in health AI to apply these best practices with institutions to co-develop in health AI.
And Mike asked a second question that I just got a message about since we're now talking about him.
Okay, but let's see. And thank you. Let's see. Let's go in order. Do we have? Sorry,
There's a question from Jackie. Can you speak more about your point around online community and support groups evolving or changing with AI and increasing digital knowledge online? How are patients thinking about these as similar or different support systems? And what are the other major factors in addition to privacy and security that may be impacting where people are going to find information and their support about their health?
Oh God, I love this question. And give me 1 second here. I have a book recommendation. Here. And let me turn off my background.
I'll put it in the chat because I
This
know
is a brand new book called AI Snake Oil: What Artificial Intelligence Can Do, What It Can't, and How to Tell the Difference. This is from 2 authors out of Princeton who are looking at the reproducibility crisis in health AI, but also there's a fantastic chapter in here that I think will answer your question. Why can't AI fix social media? You know, some of the things that are brought up in this this part is like, if we could just, you know, automate community development and trust, you know, we would be in a very different place because, you know, and again, I can't share too much about our origin story, but you know, I found certain ways to scrape online groups, and it was a very big safety concern back in 2018. We were also seeing back at the time, you know, AI was being used to kind of insert content for certain recommendations and certain ads, and we were testing it. But it is increasingly being touted as a way to moderate content. So I highly recommend reading further here because the co-author of this book was one of the AI leads at Meta before he left, went to Princeton. And I think it ties into what you're saying about community support online. We think at the Light Collective, and if you go to some of our resources, we have a resource around community-led content moderation. And our view is it cannot be done automatically. Like if you post something, there are certain, I guess, low-lying fruit things that are going to be automatically flagged, but you have to have a human in the loop that knows the community, knows the context, and understands how a tool can amplify their impact as a community moderator. But we need to be building these tools to empower community networks and the people who steward the content moderation and let them set their own rules and governance. So,
and then I'm going to add into that too, Andrea. We do have a training program for our cohorts and for patient organizations as well on the awareness aspect of this and really trying to educate populations around the idea.
Yeah. I love these. This is a great discussion. And
I'm going to add one more thing.
Yeah.
How are patients thinking about these? Some patients are not. I mean, let's just be honest. Some people are just trying to get through their diagnosis. They're trying to deal with their family, their life, their lifing, and they don't have a clue. And this is why we have worked with all of these grassroots organizations so that we can educate them and then they can educate their communities on a larger scale, because there are so many things that patients are not even aware. And then when you throw AI into the mix, just basic things about their medical records and sharing their medical records online in these support groups. They're sharing their names and their addresses and things that they should not be sharing. And they don't even understand that until we see it and we tell them, hey, you need to take this down. You need to take off this post. And especially for those who have a hereditary, a genetic mutation, because that affects not only them, but other people in their family. So we're continuing just to educate all groups of people. And now we need to go to Janice because she's had her hand raised. Janice? Janice, come off mute.
Hi, I'm sorry, I'm Lego Lady today in my picture. I just wanted to say a couple things. I really appreciate everything you guys have shared, and I too am involved somewhat with AI, and just recently was added on to the ASTP Health Equity Task Force. I haven't. I'll promote it or let people know next week, but which is interesting, right? And so a subcommittee. And what I want to make, many of you know I'm very involved with measurement. I happen to kind of fall into it via PCORI on an ask to be involved with a CMS early measure on, it's called the Innovative Accelerator Project in 2015, 16. And it was when patients were first starting to get involved with quality measurement, right? And I didn't know what I was doing, either did my other partner, but we learned very quickly. And I was fortunate to work with some of the experts, right? And anyway, quality measures generally mean clinical quality measures are about like our A1C, BMI, COPD, your breath, just very basic, what everybody wants to, health, heart rate, what constitutes generally overall at a population level, good health. So it's aggregated, and all of us are different. And as Christine had mentioned about rare disease, the truth is all of us have personalized care. Like both you, Valencia, Andrea mentioned about, like the BRCA gene or whatever. So we all have something that's unusual, maybe referred to as a mutation, but it's at very least an anomaly, however we want to look at it. So when we talk about quality measurement and AI, at this point in time, I see your AI can augment existing clinical quality measures. When we're talking about community and developing a quality measure around community and use of AI, it's something that could possibly be developed through PCORI, but you might not be aware of when you develop a quality measure, you have to also be the maintainer of it. We're talking $300,000 to $400,000 on average. People don't know how much it costs. I was shocked when
Wow.
Yeah. I found out because I was very vociferous at one meeting about ensuring that we had perinatal care, and this was before all the data came out more recently. This was like 5-6 years ago. I said, we have to have this measure, even if it's not maintained. And it was not at that point maintained, but we said we have to keep this in this set because it's so important, right? And then they went back to the developer, and there's a steward. The steward is who keeps it. It's usually CMS. But
Yeah.
patient reported outcomes might be where we want to start with AI, actually. How that's PROMs, it's called PROM or PRO, where patients, what they think about AI and it being used in their healthcare.
I am so excited. Like, first of all, Janice, you are the expert in this. And, we're just at the cusp of asking these questions right now. What an interesting time to do this work and to figure it out. What I would love to do is follow up with you and start to ask, based on all this experience you've had, and when we think about, Valencia, Christine and I were just in DC with Patients for Patient Safety. We met with HRQ, we met with CMS and Leapfrog Group. These are the groups that are really, I think, tasked with scalable quality measures. So, you know, your insight there is just so important and something that we would love to kind of follow up on and talk more about as we think about bringing patient experts with this experience in, and going back to some of the other community members within Health AI Partnership. Absolutely, we want to start partnering with clinicians to ask, how do we meaningfully implement a quality measure at the point of care? How do we agree on, you know, when we say, I think at the very basic level, like going back to some of the things in the AI rights initiative, when we say independent duty to patients, when we say transparency, what does it mean? How do we quantify it? We're not there yet. And that's going to take time. It's going to take capacity building within our networks and partnership with clinicians and communities and technology solutions that are trying to do it the right way.
Go back
just wanna
to
say
our other
thank
question.
you. Oh, I just want to say thank you to that. I just want to add once again, it's really about augmentation at this point in time, because AI can be used with clinical measures. Say, you know, say I have persistent blood pressure, right? High blood pressure. So, and maybe I haven't responded to a medication, and that is somewhere in my chart where they may be docked for my blood pressure being over 140 over 90, but this is my stasis, my normal. So that's where like AI can come in. Like, what do you do in that circumstance? And also, how can you help keep the doctor from not getting docked for having somebody with higher blood pressure?
For those of you who do not know Janice Tuft, you guys need to follow her, and she does a ton of writing in this area. I'm a big fan. I'm fangirling over here and honored that you joined. And, you know, yeah, let's definitely follow up and talk more about this. And I'd love to, just on the question of like, that's the burning question we have about what comes next, to actually get the rubber to meet the road from rhetoric to actual implementation, which I think could be very interesting for Health AI Partnership in this community. Alethea, keep me honest. We've got 6 minutes left, and what
quite a few questions in the chat.
Yeah, Christine, what I don't even
Do
know where
Sierra's
Sierra,
question. Yeah. When it comes to
just-
education and training to give patients the autonomy to make informed decisions, what level of understanding do you think it is important for patients to have? And what role should clinicians have in educating patients? I mean, I'm just going to say clinicians need to provide something brief. I mean, at the point of care, you know, just a short something telling them how AI is going to be used in their care. That is just like at the basic that needs to be provided. And we were talking in one of our group sessions, what level of understanding. We were talking about like what grade level, like should this be 3rd grade, 6th grade, 8th grade? We got to make it into different modalities, pictures and video and in print, so that patients understand, you know, what all of these things, they just have to understand.
And I'm going to say, I agree with you. Doctors should provide information, but I also think as patient groups, we need to educate each other, and we need to have that basic information. Like you said, Valencia, a lot of people are living in that moment, right? And they don't have that concern, but we need to make sure that these communities have that basic information. And I think that's what we're trying to do at Light Collective with bringing in different cohorts and our training models and trying to educate people. But it really is hard to get somebody to want to talk about something that's not tangible, that they don't know how it works or understand, and really get them to kind of realize the implications of that.
Last thing I'll say here, and I'm going to channel Isabel Duran, who's part of the Latino Cancer Institute and taught us so much as part of the Patient AI Rights Initiative. You know, one of the things that and I'm quoting her when I say this, it's not for us to frame, you know, health data literacy as a construct of literacy, implying that patient communities are illiterate. It is incumbent upon institutions and companies in the industry to communicate to us in linguistically and culturally appropriate ways, and recognize that linguistically and culturally appropriate ways are going to be diverse across different communities. So we have to partner early and often with these established networks who have seen how this has worked in the past with clinical research, what the pitfalls have been. I do have hope for, the translation capabilities of generative AI. If you have, factual information that you want to communicate in a different way, and the patient has control over how that might be communicated, write it to me in a poem, or include the right information, but make it at the level or the type of information that I want to get in my own language. That has yet to be studied. I think there's some interesting work out there, but it's definitely not going to be the same for every patient. And it's not going to be the traditional consent that we've had in the past, yet we have to represent and advance our rights in ways that haven't been done before.
And this can't be like a standard PDF consent that we sign once, right? This has to be a model of dynamic consent where we have that agency over that data and are able to really, work with that.
Well, I think we are coming up 2 minutes to the end.
Can we get a copy of the chat so we can go back and answer some of the questions that we may not have had time to get to?
For sure. I will make sure to send you guys the copy of the chat. And thank you so much for the awesome discussion and presentation. And thank you everybody for asking thoughtful questions as well. The session is recorded and will be posted on our website, hopefully in the next couple of days. And Andrea and team, I'm happy to send you guys the link so that if you want to distribute it to your community, you can. Thank you everybody for joining. Our next session, it will be on November 21st at 2 p.m. Eastern. We'll have Dr. David Weidel from a Vice Chair of AI Enablement at Mayo Clinic, talking about the AI Enablement Initiative at the Mayo Clinic. So we'll send the details of registration link as well as the other details will be posted on our website, and we'll be sharing in our newsletter as well. Thank you so much for joining, everybody.
Thank you.
Bye.
Thank you. Bye, guys. I can never figure out how to leave these Zooms.
Thank you.